all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today is a special treat that we had Dr. Paul Merrick in the morning and we have Dr. JP Saleeby with us. As we will talk, you would see what a rock star Dr. Saleeby is as well. I never come to you without being with a rock star. So Dr. Saleeby, welcome. Thank you very much for joining us.
Very glad to be here, Mobeen.
So I'm going to show your site, and can you please tell us a little bit about yourself, your practice, how to find you?
Sure. So just about me, I was allopathically trained, spent my first part of my medical career as an emergency room doctor. And then in the late 90s, I realized a lot was missing from my education, both in medical school and residency. So I went on a journey, many, many years of studying integrative holistic medicine. I got involved with hormone balance. I got involved with Lyme disease. I joined ILADS, ILADS, and trained under Dr. Richard Horowitz, who is my mentor. He's a world-known Lyme doctor. And I've been seeing Lyme patients since probably 2013. So, a decade plus. And I have a center in South Carolina. Oops. Looks like we may have lost you.
No,
Yeah,
we are
we
here just making you solo.
Oh, gotcha. Okay. So I have two centers in South Carolina, one near Myrtle Beach and one near Charleston. But we
Hmm.
have the ability to see patients in all 50 states and some international patients via telemedicine. So that's a little bit about me. It's just what we call functional medicine.
Excellent, excellent. Thank you very much. And so, for the listeners who would like to reach out to Dr. Saleeby, this is carolinaholisticmedicine.com. I will copy and paste this link over here. I will add this link to the description afterwards. It is not yet in the description. I will do it afterwards and edit that. So, with this, uh, Dr. Saleeby, thank you very much. I have always been a fan of your talks, the FLCCC conference and your talk there. It's just spellbinding. When you are speaking, we can just sit down and listen and learn, and the knowledge is flowing. This is what we used to do when some of our professors who were uber educated and experienced, and when they're speaking, you just sit down and you just listen, and the knowledge just imbibes in you. So that's
Mhm.
what happens when I listen to you. And so thank you very much. I'm a fan of yours.
Well, the
Let's
feeling is mutual, I must say. I am a member of your Dr. Mobeen, the Dr. Bean product that you have, education, a lot of basic sciences, rekindling memories of medical school and basic science. I love it. And so,
Alexa stop.
so
Sorry.
the feeling is mutual.
Thank you. Thank you very much. So, for the cool beans, the discussion today is primarily going to be for the Lyme and chronic Lyme. If you have questions for the long COVID, please fire away. But we have been talking about long COVID for a long time. I believe there is an important time to put some focus on Lyme and chronic Lyme. So, Dr. Saleeby, if we start with the chronic Lyme, first of all, tell me this: how aware is the medical community and the patients about chronic Lyme? Is this a disease and the symptoms that usually get missed or misdiagnosed?
Yeah, absolutely. So it goes back many, many years, 20, 30 years. The IDSA, the Infectious Disease Society of America, have certain protocols and certain understandings and a battery of tests that they will use to make a diagnosis of acute Lyme disease. And it's the kind of the 1-2 punch. It's a reflex. They use an ELISA test. And then if that's positive, they do confirmatory testing with a Western blot. That works very good for HIV infections, but it doesn't work too great for Lyme, especially chronic Lyme. Even acute Lyme can be missed. Acute Lyme has some more interesting factors and presentations. Kind of, they call it the summer flu. You get feverish and flu myalgias, pains in your muscles and bones, fever, rashes, things like that. Even the classic bullseye lesion is a manifestation, but it only happens in about 30% of acute Lyme cases. those are easier to pick up. You can make a clinical diagnosis, you can put patients on doxycycline for a number of weeks, and you can enact a cure. If you miss that opportunity, and it's a very small window, it can go into chronic Lyme, which is really a different animal. So chronic Lyme disease can be easily missed and misdiagnosed with things like chronic fatigue syndrome, fibromyalgia, MS, ALS. A lot of the autoimmune diseases, of which Lyme disease can trigger autoimmune. So sometimes people get sidetracked if they don't go and dig enough and make a diagnosis. They get sidetracked, and they can go on drugs that actually are counterproductive. You go on biologics, you go on immunosuppressants. Those are the worst things to give somebody, as you know, who's fighting an infection. The thing is, sometimes people get exposed to Lyme, they don't even know it. Could be as a 5-year-old child, they had a tick crawling on them, and they may have gotten a tick bite in their neck. Their father pulled it off. Everything was forgotten. They never got sick. 20 years later, they start having arthritis. They start having heart palpitations. They start having cognitive issues, and then fatigue and things like that. And sometimes it's also triggered by other things like Epstein-Barr virus or mold toxicity, mold allergy, or mycotoxin illness, or of recent years, the COVID infection or the COVID injection. That can also trigger or activate or wake up the Lyme disease.
So this is what I wanted to ask, that I feel that this is just my observation, that nowadays, because of COVID and because of the vaccine injuries, I am seeing that Lyme-like symptoms to have exaggerated as well, which nowadays some of them I think are incorrectly being bucketed as long COVID. They may actually be Lyme that has become activated. Could that be possible, or is that happening?
Oh yeah, absolutely. So not only Lyme, but there's a lot of overlap between long COVID and Lyme disease, and a lot of the symptoms are very similar. There's a tool we use called the Horowitz questionnaire. It's a 48-point questionnaire, and if you were to take that to a strictly 100% long COVID patient and give it also to a Lyme patient, chronic Lyme, their scores may be very similar. The complaints, the questions that are asked overlapped significantly. Furthermore, you can take it to a mycotoxin illness patient, only mold issue, nothing else, and their score would be the same. Or somebody who has a heavy burden of environmental toxicities like heavy metals or PFAS, estrogen disruptors. A lot of things can go wrong. Mitochondrial dysfunction is maybe what everything boils down to. So you can get mitochondrial dysfunction or immune dysfunction from COVID, from Lyme, from heavy metals. And the sequela or the list of symptoms and signs are very similar. So yes, you can get up. We have a lot of people that come in our office and say, hey, I had COVID a year and a half ago, and I have long haulers and I need help. And we are looking at them and we'll say, well, we need to check you for Lyme. Maybe you lived up in Pennsylvania for 20 years and are higher risk for acquiring Lyme, or they have other features. They may have had a history of a bullseye lesion. And so we say, well, let's check you for Lyme disease. And they're like, wait a minute, I'm here for long COVID. And I'm like, yeah, well, that might not be all that's with you. And I can say, since we've been treating long COVID and COVID infections, and some of the vax injured, I would say that of all the people we've tested, and we test a lot of people, I'd say almost 80% of the population that comes in our office are tested or screened for Lyme disease. We have only had two in all the hundreds of patients we've seen that were negative for Lyme disease. That's phenomenal. So that means the vast majority of our patients who are coming in presenting with sort of long COVID or vax injury have underlying Lyme disease and just maybe didn't know it.
That is amazing. That is phenomenal. So then tell me this, how do you diagnose Lyme or
Right.
chronic Lyme?
Chronic Lyme. So that's different than acute. Acute is a little easier. Chronic Lyme, we sometimes use certain biomarkers. We use inflammatory biomarkers like the myeloperoxidase or MPO. We use CRP, C-reactive protein. We also use a marker that's a natural killer cell called CD57. So there's different CDs, CD4, CD8, CD22. CD57 seems to be sort of assigned to those with the spirochete illness, the Lyme disease. And if they have a low CD57 count, then that's a pretty good indicator they may have an active case of chronic Lyme. So you want to have a robust CD57, 150 or better. 100 to 150 is mediocre. It's suspicious. Anything under 100 is more suspicious. And for gosh sake, if a patient has a CD57 under 60, I'm pretty sure they have Lyme. I mean, I usually don't even do the expensive $1,000 Lyme test. I'll tell them, listen, you have a history and a low CD57. And if they have a Horowitz questionnaire score of over 62, all that together is a clinical diagnosis of Lyme disease. And I'm right probably 99% of the time without having to do serology. Because even the best serology test, which is what we call a Western blot or now the newer immunoblots, they can be a little bit sort of, send you down the wrong road, especially if you don't have enough bands. The CDC and the state of New York's health department have certain numbers of criteria that have to be met. 2 or more IgM bands or 5 or more IgG bands to be positive for a diagnosis of Lyme. Well, the ILADS organization kind of throws that out because it's not very accurate. Plus, standard reference labs like Quest, LabCorp, they only use one type of spirochete strain, whereas other more advanced labs use multiple strains. So you're testing for more than just one Borrelia burgdorferi. You're checking for Borrelia satulate, a whole bunch of different ones from all over the world. They have different strains and species. Plus, you do co-infection tests to test for Babesia, Bartonella, Anaplasma. Those are all co-infections or cofactors in making people ill. So you don't want to miss any of those.
Got it. Thank you very much. Before I ask you my questions, I have one more question over here from John. So the I think you're aware of it. Our way of working is that we all the cool beans start asking you questions together. And so here is a question. Is that based on Vibrant alternate criteria?
So Vibrant Wellness is a reference lab. There's also Red Labs in Belgium. There's many other labs, IGeneX in California. Some people call it IGeneX. They all have an alternative criteria that is sort of based on the teachings of ILADS. So the alternative criteria is a little bit more lenient and open to catching more diagnoses. So it's interesting. The British Medical Journal published a paper about a year ago, and they did a sampling of Western Asia and most of Europe. For some reason, they excluded the Western Hemisphere. But anyway, they did a very large sampling of people using the traditional tests of the Western blot. And they found out after doing extrapolations that probably 14% of the world's population have antibodies for Lyme, so have been exposed. Whether they have active Lyme or not, or chronic Lyme, is another matter. But these people are testing positive. 14%, which I believe, and I believe most of the doctors in ILADS also believe it's an underestimation. I think probably a true value for that would probably be double. But, we'd have to do our own research. That's a lot of people.
That's a lot of people.
Yeah.
Yes. So thank you very much for this. So these are are there any other tools that you use, or this is the diagnostic criteria starting from these 3, and if needed, then going to the serology? Any
Right.
other tools, methods?
Yeah, so the Horowitz questionnaire is very easy. It's inexpensive. You just hand the patient a 4-page questionnaire. They fill it out, and that gives you some guidance. Plus, you can do a CD57. You can do a immunoblot. You can also do co-infections. You can also do a very good history and physical. Sometimes I can make an accurate diagnosis with just a good history, going, what we call a detailed functional medicine history, going back in social history, family, genetics. Were they vaginal delivery, breastfed? Were they bottle fed? Were they exposed to a lot of antibiotics as a child or as an adult? Do they have dysbiosis? I mean, lots of things are called into play. Plus a physical exam. Sometimes a good physical exam, we can pick things up. And then the other method of helping people come to a diagnosis. Some patients don't have a lot of money to spend on $1,000 Lyme test, and they would rather spend that money on therapy to get better. So you can challenge them. You give them informed consent, and you say, okay, we're going to use this, this, and this herbal tinctures, and see what kind of reaction you have. Number one, nothing could change. Nothing happens. Number two, you might have a Herxheimer reaction or a Herx reaction, which is a die-off reaction. I think we talk about it and happens in COVID and treating viruses too. But when there's a die-off, you have a huge release of cytokines and inflammatory markers, and people feel sick, malaise, nausea, fever. So you warn them about that, and they should report that back because that's usually a positive. If they Herx with, say, Cryptolepis or cat's claw herbals, then very likely we're hitting the nail on the head. You can also use traditional antibiotics, doxycycline, Ceftin. There are a plethora of antimicrobials that we can use, and you can warn them that they may have that Herx reaction. Or thirdly, they start getting better. And sometimes when you take a history, I always ask them, have you ever been on an antibiotic where you felt good while you were on it? Say you went to the dentist and you had a tooth extraction, and they put you on amoxicillin for 10 days. And some people say, oh my gosh, I felt so good. My arthritis went away. I felt really good. My brain fog was less. I was able to get out and play tennis for the first time in 10 years. And as soon as I finished my antibiotic, I started getting back to my old self again. So that's a good bit of history. That usually means they've got an underlying illness that's responding to a short course of antibiotics. Now, to treat chronic Lyme, you need a much longer course. And I think that's what kind of where the IDSA and ILADS butt heads is, because insurance companies don't want to be paying for a long protracted course of antibiotics and all that goes along with treating chronic Lyme. So they don't recognize any ICD-10 code for chronic Lyme disease. Some refer to it as post-Lyme treatment syndrome or something like that. But they're avoiding the kind of in-your-face, reality that there are chronic Lyme, either whole parts of the spirochete or even parts of the spirochete that are causing disease.
Got it. So then talking about the management of it, I want to start with the Hershing or Herxheimer reaction. And what is the risk and how do you manage it? I mean, eventually you want to manage a patient. So
Right.
there may be a chance that they are going to Hersh. How do you handle that? What is the approach to that?
Yeah. So herxing is on a spectrum, a continuum. It can be very mild, headache, a little nausea, to very debilitating. And in some cases, they've been reported in some cases using IV antibiotics, maybe a patient in the hospital with pneumonia getting a huge bolus of an antibiotic, and they have a tremendous Herxheimer reaction that could be fatal. Rare. I mean, there's only a few reported cases of that ever happening. But it's very, very uncomfortable. And normally patients, if they're outpatient and they Herx really badly, they'll give up on it. They'll say, oh, this is too uncomfortable. I'm just going to stop everything. And it sets them back. They go back to ground zero again, and we have to start all over. So I'm very cautious and I proceed slowly. If I'm using tinctures, I start very low, even 1 drop in a glass of water twice a day to start with, and then titrate up to 30 drops twice a day. And we need a protracted course. We're talking 3-6 months, even a year on tinctures and botanicals. Same can be said for some of the antibiotics. And then you have to switch antibiotics or pulse them, because the spirochete will go into, when it's being stressed or being attacked, it'll go into different forms. The S form, L form, it'll go into a cystic form and hide, and that becomes resistant, or the antibiotics don't penetrate that cystic form. So you may have to switch from something like amoxicillin or penicillin class drugs, cephalosporins, and doxycycline and tetracycline to something like a fluoroquinolone like ciprofloxacin, or Flagyl, rifampin. Some doctors are using dapsone, which is an old anti-abuse drug. They're using disulfiram. Those are pretty harsh drugs. And then if they're co-infections, you may have to use things like Mepron or Malurone, azithromycin, to treat Bartonella and Babesia. So it gets pretty complicated. No two patients are the same, so you can't cookbook it. You can't formulate a one-page handout. Well, here are all the drugs you need to take. Good luck. Everyone's individualized, so you have to figure out what's plaguing them, and then you direct your therapy against what microbes they have. And it could be other things like Epstein-Barr, CMV, HHV6, COVID, could be Mycoplasma pneumoniae. There's lots of other things that could be going on. They could have a gut that's messed up, dysbiosis or SIBO, and that plays a fact. Their hormones may be all out of whack, and then you have to contend with that and get those on track for them to completely recover.
Got it. Thank you so much for this. Just a very quick note once again for the viewers who are new or who are just joining us. Today we have Dr. JP Saleeby with us, and we are discussing with him chronic Lyme, and if we got a chance, we'll talk about long COVID as well. And I just want to very quickly show you, again, I have no strings attached here. Here is Dr. JP Saleeby's clinic's address, carolinaholisticmedicine.com. So there is a button here that says contact us, and you can go there and you can see there is a form to contact them. There's an email address. There is a phone number as well. So let's continue to listen in. This is a topic that is really close to my heart. So I have a question here. When you are going to manage for chronic Lyme, one aspect of that is the chronic pain or severe pain.
Mm-hmm.
And what I have observed is that we have been using the opioid-based painkillers as well. Then nowadays there is this movement to wean away from the opioid-based painkillers.
Right.
Patients are now left without a decent solution, and they are becoming immobile. They are getting into severe pain. They are just sitting out there in real bad state. How do you manage this? Number one, is it necessary to move them away from opioid-based painkillers? And number two, if you do that, what is the right approach instead of just saying, we're going to wean you off of this painkiller and then good luck? What is the right approach?
Well, the pendulum has swung from one side to the other. I think there are several factors involved in the opioid crisis. There is the pressure by pharma to convince doctors it was the right thing to do. I remember they used to come in to my office when I was in the emergency room and they'd say, oh, this is non-addicting, it's safe to use, and come to find out that they weren't telling us the whole truth. People were getting addicted. As we know, there's litigation now and class action lawsuits against pharmaceutical companies for doing that. And now the doctors who were kind of a little bit sloppy and didn't do their due diligence were handing out opioids like candy. You had Suboxone clinics popping up, methadone clinics to try to deal with things. And now the pendulum has swung to the other side where everyone doesn't want to talk about it. Like, don't bring up opiates. Oh, you're a drug seeker. Get out of my office. And there are instances where opiate painkillers are useful in the short term, but we got a little bit sloppy. So now, somebody goes in with legitimate pain and they only get 5 Percocets, after surgery, and good luck, pat on the back, after that, after those 5 pills, you're done. So there are things you can do. You can use non-opioid, non-centrally acting agents. You can use a mix of that with non-steroidals and natural agents so that your reliance on long-term use of opiates is limited and not necessary. Things like curcumin, high doses of very high-grade curcumin, resveratrol is helpful. Then, of course, you have low-dose naltrexone. And if you dose it properly, there's many, many ways to dose naltrexone. and it can be used as an adjunct to some of the natural agents, Boswellia serrata, curcumin, things like that, to help with pain. You can use very low dose naltrexone, twice a day dosing, what we call BID dosing, can help with pain. And as you titrate that dose up, you can sometimes exact complete pain relief. Happened to me with a patient who was taking 3 milligrams of naltrexone BID, and she called back in a few days and said, for the first time in 10 years, I am completely 100% pain free. And this was on a
Interesting.
fairly high dose. Yeah, 6 milligrams per day, total daily dose, but dosed twice daily. Um, so so that's what we do for pain. You can also integrate things like acupuncture, traditional Chinese medicine, acupuncture. There's a Chinese massage that's helpful. There's therapeutic medicinal massage that's helpful. Stretching, yoga, meditation. There's also other kinds of energy medicine that can help with chronic pain. You don't have to put people on Percocet, you know.
Mm.
But for those who've been on it for years, you have to be careful. You have to wean them off and find adequate substitutes. But I'd say for the majority of people who have been using opiates chronically, there is a way out. It's not a one-way street. You're not locked in prison there, bound to these medications. There are ways to get out. And
That's very
I might ask. I didn't really answer the question. You said, "What do you do for somebody who's herxing?" Well, there's lots of things for herxing. Transresveratrol or resveratrol, which is also known as Japanese knotweed, or polygonum, is one thing we do. You can use quercetin. You can use hydration, both oral or IV hydration, Epsom salts baths. You can use sauna, both near and far infrared sauna, or steam saunas to help. You can use therapeutic massage. Alka-Seltzer Gold, you usually have to order that off of Amazon. That alkalinizes you and helps release some of these cytokines. So there's a list, a handout we give our patients. So if they're herxing really badly, and that's pain, that could be a lot of pain, we use these little tools and tricks to help mitigate that problem.
got it. So I have a question about the cost of this all, but before that, I'm going to quickly involve cool beans in here as well. Margaret McInnes says, can patient with decades of positive tests for Lyme and co-infections be helped, especially in neurological deterioration?
Absolutely. There's no end game. There's no late stage where you kind of throw up your hands and say, well, you've had this for 45, 50 years. There's nothing we can do. Everyone's different. Everyone will respond differently. But I've had patients who've had 20 years worth of Lyme, just maybe didn't find the right doctor, but they've come to us and we've been able to help them, sometimes as short as 6 months. On average, truthfully, 1 year to even 2 years for the hard cases of Lyme and co-infections. And then on rare occasions, we've had people get 100% better in 3 to 4 months. I had one recently who came in. He was vax injured and Lyme disease, was in really bad shape. And within 5 months, he was 90% better. I did a telemedicine, and his wife was standing behind him, jumping up and down, just cheering and so grateful that she had her husband back. He was not that optimistic initially because he had been through almost a year of going to every specialist he could find, and nobody helped him. And he was dismissed as being, well, you're crazy. It's all in your head. But we were very successful in treating him fairly quickly, even to my surprise, how fastly he responded to therapies.
Got it. And thank you very much for helping patients. I have a question about the cost.
Mhm.
So, if insurance isn't very much willing or recognizing of these issues, and the patient has to go on for months and maybe years, how are patients able to handle the cost? Is it expensive, or are there cheaper solutions? How do you approach it?
Yeah, well, we have to operate. Most Lyme literate docs, most functional medicine doctors have to operate outside of insurance. The insurance model doesn't understand what we do. They do not reimburse us for our time appropriately. So we have to do what we call DPC, direct primary care, or cash practices. Now, what we do in our office, you can go visit by visit or fee for service, or you can join one of our care plans. So if we identify you as a complicated patient, we have a special plan called a restorative plan, and you can pay it in full, you can pay it monthly, like a gym membership, if you will. So the impact on your wallet, on your bank account, is minimal. We're talking anywhere from $150 to $210 a month, but the return on that investment is amazing, because in the short term you might say, "Oh my gosh, that's expensive," but in the long term, if you look at 5, 10 years, we're probably saving patients $100,000. That's $100,000 you will save by coming to a functional medicine doctor and getting fixed. And then you have your life back. You can go back to work or enjoy your retirement or whatever it is. And you don't have to spend all your time in a hospital getting MRIs and CAT scans and running up all this expensive stuff. So you get to keep that in your pocket. But it's understands the philosophical difference of what we call transformative instead of transitional care. Like a transaction is like giving somebody money. We're doing transformative care. In other words, we're giving you your life back. It's a philosophical difference there. So, and the thing is, we graduate people from our practice. We have patients that have been with us 2 or 3 years, and then after that, they come back only once a year. They don't need to come back every 3 months or every 2 months, because they're fixed. We fix them and we educate them, and they know what to do. So if they have a flare up, they know to go for the cat's claw, and they know to go for the banderol, and they know to get on Immucor, and they can fix themselves. They can stave off a flare up. And then of course, when things get out of hand, they'll come in. But like I said, we graduate people. They become once a year folks that come in just annually for a visit.
So then one more question, which is coming in my mind as well. Can patients from the whole United States reach out to you? What states do you practice in? What is the way? So I see that you have a hope here. And again, for the listeners, I do not have any financial or any other strings attached. I just am bringing, I think, important information. So how do you practice in all states?
Yes. So our practice as it is now has been in existence since 2013. We have 2 locations in South Carolina. We are all of our providers. I have 6 other very well trained. I train them myself, nurse practitioners and physician associates. They all go through my curriculum. I have actually an academy to help train them. They're all excellent, and we are licensed in North and South Carolina in the beginning. And then in October of last year, we were able to get to where we could take care of patients in all 50 states and some international. I have patients in Russia, in Australia, New Zealand, Canada. So we are able to take care of those patients internationally. We are able to, through a special PHA, that's Private Health Association, take care of patients in all 50 states by telemedicine. We do it mostly by telemed.
Got it. Thank you very much. And I want to ask some of the questions from the Cool Beans as well. And Cool Beans, if you write more questions, please write some Q or something so I can identify it. Here is a question. John says, curious to know if Dr. Saleeby does live blood analysis.
Yeah, well, John, I don't do live blood. I know some clinicians that do. My good friend Pierre Corey, I understand, does some of that in his clinic when he's treating some of the vax injured folks. It's kind of a popular thing. I tend to be kind of low tech in some regard. I have what I practice is I call reformed functional medicine. So if you go to the big academies of functional medicine like IFM, they kind of preach over testing. Live blood analysis, oat testing, a lot of testing gets expensive. I like to think that with my years of experience, I can use my 2 ears and my eyes and my brain to kind of figure a lot of things out. So, what are you going to do different necessarily with live blood analysis? I'm not wholly sure. A lot of the things I rely on are pretty successful. I like to challenge people with therapies and see what works. So it's a different paradigm, a different approach, if you will, to making a diagnosis and treating. Kind of going back to the days of Galen and Imhotep, where they didn't have an MRI. That's something of recent years, but they had a brain and they were good diagnosticians and they could figure things out.
Got it. Thank you very much. Uh, Jean says, are cat's claw and cryptolepis the herbs that you use for the challenge?
They are. I use Cryptolepis. It's pretty amazing. It's got a lot of traffic on some of the research in the last 5 years. I like the Cowden protocol, so Banderol and Cemento. Cemento is their version of cat's claw. We use wormwood. We use Cryptolepis. We use Inula and Mora, depending on the co-infections, even Hootenuia. So there's a lot of botanicals that we use that we borrow from the Cowden protocol, as well as Dr. Stephen Buhner's work. He's a California doctor. He passed away about a year or two ago. Great doctor, wrote Healing Lyme in two editions. Great book to reference. Also, Dr. Richard Horowitz wrote How Can I Get Better? He's written a couple of books on Lyme, and he's given many lectures. Also, a shout out to Dr. Tom Moorcroft. He's another Lyme expert. So we all kind of get together from time to time, take each other's lectures and classes and network with one another. But yeah, so cat's claw is an amazing botanical, and cryptolepsis as well. You got to know how to use them. Sometimes with resistance to that, we'll use teasel root and some other botanicals, but there's many to choose from.
Got it. Thank you so much. There is a question here from Andra. What about people allergic to plants? Can you treat them? I have glottic edema from botanicals.
Yeah, so we have to worry about someone like you with MCAS, mast cell activation syndrome, and also doing a thorough analysis, IgG, IgE mediated allergies. And yes, I mean, we don't have to use plants. We can use, synthetic drugs if that's the preferred method. I'm not disinclined to use doxycycline and Ceftin and a few others. I find, though, however, using botanicals is an easier way and more gentle way to treat. And there's been some research, for instance, by Dr. Avasapi up in the University of Connecticut, comparing in vitro, comparing doxycycline, Ceftin to Banderol and Cemento, and having good, kill rates without the collateral damage that antibiotics cause. But if you're averse to plants, then we certainly would use traditional antibiotics.
Got it. Thank you. Uh, Cheryl says, we have questions and we're going to get your recipe out today. So Cheryl says, I was just reading about devil's claw for my knee arthritis. Will that help me? And once again, for the viewers, we do not have medical advice here. These are more educational and discussions for medical professionals.
Sure.
So,
So there's hundreds of botanicals that can help with arthritis. Cat's claw is actually pretty good for arthritis, migratory or inflammatory arthritis. Devil's claw, yes. I mean, you can try these things if you read a good article and it's substantiated by some research and appears to be level, not too good to be true. You know what they say about if it's too good to be true. You can try it. Make sure you run this by your clinician or your doctor, your naturopath, your MD, whomever's taking care of you. It's best to not approach it as a do-it-yourself kind of thing because that gets people in trouble. But run it by your doctor, and what you can do is test it. If it works, stick with it. If it doesn't, give it up. I tell my patients, we're not going to put you on something for a year. If it doesn't work in 3 months, we're moving on. Also, I would recommend considering low-dose naltrexone as an adjunct to whatever you're doing for your knee pain, and even peptides. Talk to your doctor about using selective healing peptides to heal that knee.
thank you. John says, does Dr. Saleeby use binders as a part of treatment? I understand that this isn't medical advice.
So yeah, binders. So binders are typically used if you have environmental toxins or you're trying to chelate heavy metals. So in the heavy metal situation, early on in my career, I trained ACAM, and they were doing pretty aggressive IV chelation therapy and EDTA, DMSA, DMPS. I found those to be pretty harsh. So now I use mostly botanical binders, uh, clays. There are certain types of clay binders and activated charcoal, which are helpful. Also, with mycotoxin illness or mold illness, those mycotoxins are very sturdy molecules that don't get broken down too well. So you have to pull them out. So you have to have a healthy gut, in other words, a good microbiome, and you need to test for that if you're not sure. And then you can use those kind of binding agents to bind those toxins and pull them out in your excrement. I tend to stay away from some of the synthetic binders like cholestyramine. It's pretty harsh, has a lot of side effects. If you don't brush your teeth after you take it, it can eat the enamel off your teeth. So that's not a good thing. So I kind of stay away from cholestyramine, but I'm very pro, mineral binders, like a product GI Detox by Biobotanicals or the Biocidin Company is a very good binder with bentonite clay and activated charcoal, a little aloe to kind of help push things through.
Got it.
Hopefully that
Thank you very
answers
much.
his question.
Thank you very much. So just a quick comment for MJ Pierce. So MJ, one of my cats, Kyrie, is sleeping right next to me. Luffy's downstairs. Luffy has, you may have been new to the channel. Luffy has always been this loud mouth, and he always tries to tell on me for the wrong things. I've never done anything to him, but he would do this horrible sound, and he would make it look like he's under some sort of a problem. But rest assured, his food is there, his water is there, the door is open, he can go out. We are all at his service whenever he wants it. So, with this, a couple of more questions that are interesting. This is on the long COVID side. Eddie says, have long COVID started taking nattokinase, felt fine. On day 4, feel extreme fatigue and other COVID symptoms come back. So, does nattokinase kind of help cure, or is it just a supportive medicine?
Well, nattokinase, you better than me, Dr. Mobeen, is because you've lectured on this, and you've done a deep dive. You and Paul Merrick have studied this ad nauseum. So nattokinase, is an enzyme that comes out of natto, which is a fermented soybean product that they use in Japan and in Asia as a food. It happens to break down fibrin, so it may be very helpful in also chopping up or breaking down the spike protein. There are other proteolytic enzymes that are also helpful, lumbrokinase, serrapeptase. If one is not working anymore, maybe you need to switch it or maybe increase your dose or find a product that's more pharmaceutical grade. I mean, there's a lot of stuff out there on the market, so make sure you're getting the good stuff. But if this is for neurological symptoms, I've recently put together the NeuroPASC protocol that we use, and there's a lot to it. We're using methylene blue, we're using augmented and acetylcysteine, memantine, which is Namenda. It's an old Alzheimer's disease drug that we're finding helpful. Fulvalic acid, guanfacine, which is used in some people with ADHD, oxytocin, mebendazole, which is an antiparasitic like ivermectin, but it crosses the blood-brain barrier, might be helpful. We use cryptolepis, believe it or not. That's a botanical that we've taken from the Lyme, and we're throwing at neuro and other long hauls COVID injury. Gabapentin, nicotine, sometimes nicotine gum or patches may be helpful. And then there's a product called NeuroPX by Restorative Formulations, and it has Tudica, Tudca, Tudica in it. It has ashwagandha. It has nicotinamide riboside that helps support the mitochondria, and some other agents. IV therapies like the Myers cocktail, or just Keith Berkowitz talks about just giving a people a liter of normal saline can sometimes wake things up and open up their detox pathways. So that's helpful. Glutathione IV is helpful. And Mlexinox is another agent, kind of an older drug with new uses, another off-label drug. Writing on that. I use a lot of LDN, obviously, and mitochondrial support. And incidentally, for anosmia, I'm reading off of a protocol that I'm writing. Theophylline nasal spray. So theophylline is a drug that's used for asthmatics, and there are some studies, even pre-COVID, for folks that have issues with smell sensations or anosmia or gustia, they can't taste. Topical use of theophylline or aminophylline has been helpful in some cases. So if that's something that plagues you as part of your long COVID, that's something to consider. Talk to your doctor about it.
Thank you very much. And my just quick comment here is that if Netto is not working, after you leave it, or it just stops working, you have to figure out what is the underlying pathology. And for that, once again, folks like Dr. Saleeby here, or there are other folks as well, reach out to them and have a more methodical approach to trying to figure out what is wrong and then attacking it and trying to get rid of that problem. So very good question. Thank you. Couple of more questions. I know that it is almost an hour and you are on the East Coast, correct?
Yes, we are East Coast time. Yes.
So sorry that it is so long. So just a couple of more questions.
No problem.
Here's a question from Jean. She says, you mentioned Stephen Banner's herbal contribution to Lyme. Have you explored his suggestion, herbal and supplemental treatment for COVID and long COVID, proposed March 2020, some overlap in both treatments?
Yeah, so Stephen Buhner's work, he passed away, I want to say 2 years ago. So this was probably work of his that I'm not totally familiar with. I kind of took a dive into what was going on with the FLCCC and doing that kind of research. So I'm not aware of what his supplement and herbal recommendations are, but I would imagine they're very close to his Lyme recommendations. Things like CSA, Cryptolepis, Andrographis. I like Andrographis a lot and use it a lot as even in preventive care. There's a product called Andrographis Immune, which has melatonin, selenium, and zinc in it. So it's a nice combo therapy. So there's a lot of folks putting forth different protocols or different suggestions, but that didn't come really across my radar.
Excellent. Thank you very much. And one last question. Guess what are we going to end our discussion on? Ivermectin.
Of course.
So the question is by Barbara. So Barbara says, does ivermectin make Lyme worse?
Okay. So if you've taken ivermectin and you've got underlying Lyme disease, you're probably herxing. So it will not make it worse. We used ivermectin before COVID came along. So 10 years before COVID hit, I know I was working with Horowitz and his clinic, and he was prescribing not very often, but occasionally, because back then even it was kind of difficult to get the right dose. But we did use ivermectin in our Lyme patients. And incidentally, I had a fellow who was a very brittle Lyme patient. He had Lyme and multiple co-infections. He was very, very hard to treat. He was misdiagnosed with lupus for many years, and we had him in remission until he got COVID. When he got COVID, he came out of Lyme remission and it got reactivated. And he was taking Alenia, nitrous oxide, and that was the magic bullet that got him in remission. So we said, hey, let's switch gears a little bit. Let's put you on ivermectin for your COVID. 3 weeks later, he comes back in the office. He says, oh my God. He said, my COVID it kicked its butt. The ivermectin kicked its butt. And he said, oh, by the way, I think this ivermectin thing is working for my Lyme, because he said, I've felt the best I've felt in like 20, 30 years. So then we started pulsing him with ivermectin, switching it back and forth between that and nitrous oxide to keep him pretty stable and in remission.
Very interesting. Thank you very much. So with this, Dr. Saleeby, thank you very much for being with us. Thank you very much for your time, for your insights. And I always say this for our guest physicians. Thank you for the hope that you bring to so many who are suffering. And I want to once again show your site, how to find you. So this is Dr. Saleeby's clinic, Carolina holisticmedicine.com. And over here there is contact us button over here. If you go there, uh, it is my network.
Oh. Well,
It is
Mobeen,
my network that just did it. So
yeah,
anyways, once we go to the contact us and we have the contacts.
yeah.
So Dr. Saleeby, thank you very much for being here.
Thank you, Mobeen. It's been a pleasure, and please continue your good work with your podcast and bringing knowledge and wisdom to all the folks that follow you.
Thank you very much. And Cool Beans, have a nice weekend. I would see you on Monday. For those Cool Beans with whom I do a morning walk, tomorrow I'll be morning walking with you in from my car because I have a business meeting at 8 o'clock and I'll be setting off at 6:30. So I'll see you tomorrow from my car. So once again, Dr. Saleeby, thank you very much and good night all.
All right.